Pulpotomy. Dental pulp is a loose connective tissue which occupies the center of the tooth. It measures about 0.1 cc in volume and occupies the central portion of each tooth. The main function of dental pulp is to supply nutrients and oxygen to the tooth so as to maintain the vitality of the tooth. It also helps the tooth in maintaining its form and function. The other functions of the dental pulp are to retain the sensation of the tooth and even proprioception. Now, if there is any physical, chemical or mechanical insult to the pulp by the means of either traumatic injury or the caries process, the dental pulp will become infected or affected. Further, it will become inflamed. So, the inflammation of the dental pulp is referred as pulpitis. Now, pulpitis can either be reversible or irreversible, acute or it may be chronic. Now, what is reversible pulpitis? Reversible pulpitis, it is the state of the pulp in which it can be reverted back to its original form, function and shape. Whereas irreversible pulpitis is a state of dysfunction of the pulp in which the pulp cannot be reverted back to its original state. There are various treatment modalities for this irreversible pulpitis. But first we should know how to diagnose the tooth, whether it is facing irreversible pulpitis or it is having a reversible pulpitis. Now, what are the signs and the symptoms of irreversible pulpitis? If the patient is having spontaneous pain or nocturnal pain or pain on mastication, if the patient is having an abscess, sinus or fistula, such patients are concerned of irreversible pulpitis. And in reversible pulpitis, the pain goes off even after removing the stimulus. There are various treatment modalities as I have already told for the irreversible and reversible pulpitis. They are classified in primary and young permanent teeth as pulpotomy, pulpectomy, direct pulp capping and indirect pulp capping, and also apexification and apexogenesis. The direct pulp capping, indirect pulp capping and pulpotomy are indicated in vital teeth, whereas the pulpectomy and apexification in direct pulp capping. The pulpectomy and apexification is used in non-vital teeth. Apexification and apexogenesis are the procedures which are used in the teeth in which the apices of the root are still not closed. So, what are the major goals of pulp therapy? The main objective of pulp therapy is to maintain the arch length. It also helps in restoring the comfort and chewing ability of the child or the patient. It prevents any speech abnormalities or even abnormal oral habits to develop in the child. So, the pulpectomy or pulpotomy or any of the pulp therapy procedures that maintains the successful treatment of cariously involved pulp, allowing the tooth to remain in proper form and function in the oral cavity. So, let us know what is pulpotomy. Pulpotomy can be defined as the complete removal of the coronal portion of the dental pulp followed by placement of a suitable medicament that will promote the healing and prevent the vitality of the radicular pulp. So basically in pulpotomy, what happens, the coronal pulp is infected. So we remove the coronal pulp, but the radicular pulp is still vital. So we preserve the radicular pulp by the means of application of various medicaments. So pulpotomy is the removal of the pulp and preservation of the vital pulp tissue in the radicular region of the tooth. The major objectives of pulpotomy are to remove any inflamed coronal pulp that is present in the tooth, and finally to maintain the tooth in the dental arch in the form and the function as it is in normal state. Now, why do we do pulpotomy at all? It is for the purpose of surgical amputation or removal of the coronal portion of the dental pulp, further preserving the radicular portion of the dental pulp to its vital state, and maintain the arch length and the tooth in proper position and integrity. Now, the various indications of pulpotomy, or how can we select? Now, what is the selection criteria for the tooth which have to be pulpotomized? There are certain clinical, radiographic and symptomatic indications of the same. Now, if the tooth is having a large carious lesion or is largely cariously exposed, or if the tooth is traumatized, exposing the pulp, for example in young permanent teeth, and if there is a mechanical exposure of the pulp which can be iatrogenic in nature by the dentist and which is not infected, if there is no persistent pain or spontaneous pain in the tooth, if there is no nocturnal pain or pain on mastication, that is, there is no pain in the tooth, but the tooth is having a large carious lesion and the pulp is exposed. Now, on exposing the pulp, if the hemorrhage is there and which can be easily controlled or amputated, pulpotomy is also done in vital tooth which have wide open apices. It is mandatory for the presence of at least 2/3 of the root length. That is, the root should be patent. The tooth should not be mobile. And the life of the tooth should be more in the oral cavity. There should be absolutely no signs of internal or external rarification or resorption. And the tooth which is restorable. Generally, grossly destructed tooth do not go for pulpotomy. That is, extraction is generally indicated in which the coronal structure is not there. Even if abscess, sinus or fistula is present or the tooth is mobile, we do not do pulpotomy in such tooth. It will either go for pulpectomy or extraction. Now, there are certain contraindications for the same. They can be either represented by the history, the radiographic examination and the clinical examination. If the patient complains of a sharp, excruciating, throbbing pain in the tooth on mastication and the pain lingers for a long period of time, that is, even after withdrawing the stimulus or stopping chewing or mastication, the pain persists in the patient, we can say the tooth cannot be pulpotomized. Then there are certain medical conditions like hemophilia and certain cardiac diseases which may be congenital in nature. In such conditions, pulpotomy is contraindicated absolutely. On clinical examination, if the tooth is mobile, if the tooth is having any discoloration or abscess, sinus or fistula, in such cases we do not go for pulpotomy. On radiographic examination, if we see that there is any defect in the lamina dura or there is a thickening of the periodontal ligament space or any resorption or rarefication in the furcation, any resorption or rarefication in the lamina dura, and more than 2/3 of root length is lost or internal or external resorption in the root is found. In such cases, we do not go for pulpotomy even. Now, what is the various types of pulpotomy? The classification of pulpotomy. It can be classified based on the method of pulpotomy into devitalization pulpotomy, then preservation pulpotomy, and regeneration pulpotomy. So, what is devitalization pulpotomy? As the name suggests, devitalization pulpotomy can be either mummification or cauterization type of pulpotomy. That is, the pulp is totally devitalized. It can be possible by either of the medicaments. It may be either single sitting or double sitting procedure. In single sitting, formicrosol, electrosurgical pulpotomy and laser pulpotomy can be performed, whereas in double visit or dual visit pulpotomy, GCs, triopaste, Islix, formaldehyde and paraformaldehyde devitalizing paste is used. So in devitalization pulpotomy, it generally the medicaments cauterize the pulp or devitalize the pulp, but there is no regenerative procedure or preservation procedure for any of the pulpal components. In preservation pulpotomy, we can preserve a part of the pulp and there is minimum devitalization. Glutaraldehyde, ferric sulfate and zinc oxide eugenols are the medicaments which are used in such type of pulpotomy. Now what is regeneration pulpotomy? In such pulpotomy, inductive process can be operated in the tooth. It is the reparative type of pulpotomy in which the dentinal bridge formation takes place. The various medicaments which are used in such type of pulpotomy are zinc oxide eugenol, calcium hydroxide, bone morphogenic protein or BMP, the enriched collagen, freeze-dried bone and the osteogenic protein which can be either albumin, globulin, etc. Then, depending on the number of visits, pulpotomy can either be single visit, two visit or in multiple visit stages. Depending on the amount of the pulpal tissue removed, it can either be complete, that is total, or partial. So coming over to the most popular and the most prevalent form of pulpotomy, type of pulpotomy, which is formicrosol pulpotomy or the single-staged pulpotomy. It was first advocated by Sweet in the year 1930. Dr. Sweet advocated the multiple visit type of pulpotomy, which was further modified into single visit by various other scientists. So, Dr. Sweet used a medicament called formicrosol or Buckley's formicrosol in this procedure. Now, let us see what is the composition of formicrosol. It constitutes glycerine by 15%, water by 31%, cresol by 35% and formaldehyde, which is the main ingredient, by 19%. Now, how can we prepare Buckley's formicrosol? Here we take 3 parts of glycerine to 1 part of water is added. After this, 1 part of formicrosol is added to this 4 parts of the diluent which is obtained. That is, if there will be 90 ml of glycerine, to that we can add 30 ml of the sterile water, which will be equal to 120 ml. and then to this 120 ml of the solution obtained, we add 30 ml of the formicrosol, which will come up to 1/5 of the strength of the solution, or 150 ml of the diluted formicrosol, which is obtained by the following procedure. Generally, 1/5 concentration of formicrosol is used for the procedure of pulpotomy. It can also be equated as 20% of formicrosol by weight. Now, the glycerin can act as a preservative, and it prevents further polymerization of any of the constituents. Cresol is having destructive properties to the vital tissue of the tooth. Now, what is the mechanism of action underlying this formicrosol application? What happens whenever we place a pellet of formaldehyde in the pulp chamber? Formaldehyde gas is liberated. This formaldehyde gas fixes the pulp. But how? The aldehyde side chains of the formaldehyde gas, it combines with the pulpal proteins and the proteins or the amino acid which is present in the bacterial cell wall, which will cause the coagulation and irreversible denaturation of the proteins which are present. It will also cause coagulative necrosis, thus fixing the pulpal tissue. It is with a certain delay in formicrosol but immediately in glutaraldehyde. So, resultantly, an acidophilic zone is formed in the pulpal tissue. But there are certain zones. The immediate zone after the application is called the zone of fixation. The zone below lying it is the acidophilic zone or the zone of coagulative necrosis, and the lowermost zone towards the apex is the vital zone. The eosinophilic zone is the broader one, and there is a paler staining zone of the zone of atrophy, and the cells are not properly defined in this zone. Then finally, there is a zone which is zone of inflammation, which is present apically. So after 1 year, all the zones are themselves destroyed, and only the zone which is the acidophilic zone is left over after a year. Now, coming over to the major technique of this pulpotomy procedure, that is, what are the various steps which are involved in pulpotomy. So before starting any procedure, it is mandatory to administer local anesthesia to the patient in order to prevent any discomfort of the patient and the operator as well. After local anesthesia administration, rubber dam is applied in order to isolate the tooth from any saliva or any further functional operants. The root and the tooth is entirely isolated. Then what happens? The operatory procedure is started. We start by using a round burr. The round burr is helped in cutting the enamel as well as the dentine. The outline formed is maintained. The overhanging enamel of the tooth and any infected dentine is finally removed from the floor as well as the lateral walls before entering the pulp chamber. That is, the tooth is cleaned of all the caries which is present. After cleaning the tooth from the caries, a straight line access should be obtained to the pulpal chamber, and the roof of the pulpal chamber should be removed. This can be done by a large axis round burr and the straight cutting burr, moving from inside to out. Thus, finally, if a straight line axis is obtained and we can see through the pulp chamber, that means final axis preparation is done. After the axis preparation, we further move to removal of the coronal pulp. This can be done by the use of a slow speed handpiece or a round burr or a sharp large spoon excavator, and the entire coronal pulp is scooped out. After scooping out the coronal pulp, the pulp is irrigated to remove any overhanging pulp tissue remnants, and when the pulpal tissue remnants are all removed, the attempts to arrest hemorrhage is done, which can be done by the means of a sterile moist cotton pellet, and pressure is applied on the pulp for a few seconds of time. After that, the pellet is removed, and if there is the cessation of hemorrhage, then we apply a pellet which is soaked in formicrosol to the pulpal chamber orifices. Then finally, it is kept on the pulpal chamber for a time period of 4 to 5 minutes. Then this duration, the formicrosol which is present in the pellet will diffuse slowly into the radicular pulp and fix the radicular pulp in the time being. But care should be taken that before application of this pellet, the excess formicrosol should be squeezed out on a gauze piece, because formicrosol in excess quantities will lead to diffusion from the apical foramen and may further lead to toxicity or mutagenicity too. So we can see in the pictures that the removal of the pulp chamber, the removal of any debris of the pulp, the removal of the wall, the floor of the pulp chamber is checked properly, and the removal of the entire roof is done. Now, how can we differentiate that we have reached the pulp chamber? It is the law of the color change by which we can differentiate the pulp from the walls or any coronal portion of the tooth. The pulp chamber is darker in color than the surrounding tooth walls. So finally, we can see in the pictures that with a large spoon excavator and a large round burr, the pulpal tissue is removed. Application of formicrosol, the squeezing of the formicrosol for any excess, and finally placing the formicrosol pellet for a period of 5 minutes to fix the radicular pulp. After placing of the formicrosol pellet, we can see that the radicular pulp has been fixed by denotion of the blackish color of the radicular pulp. Then finally, the thick mix of zinc oxide eugenol paste can be placed on filling the entire coronal cavity, which is topped over by any zinc polycarboxylate cement or even glass ionomer cement, and the tooth is finally restored to its form and function by the means of stainless steel crown. These pictures we can show the radiographical appearance of the zinc oxide eugenol paste which is placed in the tooth, finally any zinc polycarboxylate cement or GIC, and the restoration of the tooth by the stainless steel crown. Now, in pulpotomy, only care should be taken is that on application of the cotton pellet, if the hemorrhage is arrested, then only we can progress further with the pulpotomy procedure. And even if the clot is formed, the removal of the clot is done, and after that the formicrosol pellet is placed in the pulp chamber. Now progressing further to the modified formicrosol pulpotomy. It was given by truss in 1972. It is generally indicated in young permanent molars which have to be removed or retained to the teeth in the oral cavity for only a short period of time. In this, nothing is done but only a formicrosol pellet is placed in the pulp chamber and continuously and completely sealed permanently in the tooth. Now, what is two-visit or dual-visit pulpotomy? It is a two-stage procedure which involves the placement of the paraformaldehyde paste along with the cotton pellet in the coronal pulp chamber and finally removing it, and in the second visit restoring the tooth. This is a two-stage procedure. But what are the various indications for the two-visit pulpotomy? If on opening of the pulp chamber we place the cotton pellet and it is seen that the bleeding from the pulp chamber is sluggish and the operator is unable to control the bleeding at that point of time. Then secondly, if there is pus in the pulp chamber but not in the radicular portion of the tooth or not on the amputation sites of the tooth. If suppose there is thickening of the periodontal ligament space and if the patient gives history of pain. In such cases, these are borderline cases in which dual visit pulpotomy is performed. The various contraindications for this technique is if the mobile tooth is there, if there are sinus, fistula, abscess or a non-restorable tooth or a tooth with a necrotic pulp. In such cases, we perform pulpectomy procedure. Now coming over to the step-by-step procedure of the two-visit pulpotomy. All the steps are almost the same to the single-visit pulpotomy. First of all, anesthetizing the tooth for the purpose of comfort of the patient and the operator, isolating the tooth from any saliva by the means of rubber dam, then preparing the oral abscess cavity, then finally obtaining the straight line abscess or axis in the tooth, the deep carious lesion, everything, all the dentinal shavings, the overhanging enamel, etc. are removed from the tooth. A clean, sterile abscess is obtained. Enlarge the exposure by the means of a round burr. Now, a cotton pellet is taken and the paraformaldehyde paste is incorporated in the cotton pellet. And finally, we place this pellet over the exposed pulp in the enlarged axis preparation and we seal it for 1 to 2 weeks. In the meantime, the formaldehyde gas from the paraformaldehyde paste diffuses into the radicular pulp and fixing the tissues. Now, on the second visit, that is after 2 weeks, the patient is recalled. Again, local anesthesia is given to the patient. All the cotton pellet is removed. The pulp chamber is deroofed and the entire pulpal cavity, the coronal pulpal cavity is cleaned by the means of saline and other irrigating solutions, which is finally dyed by a cotton pellet. The pulp chamber is then filled with an antiseptic paste and finally the tooth is restored by the means of a stainless steel crown. Now, what is the difference between the medicaments, that is glutaraldehyde and formicrosol, which is used in pulpotomy procedure? It is often considered glutaraldehyde to be superior than formicrosol in the fixative properties. That is, glutaraldehyde fixes the pulp tissue instantly, whereas formicrosol or the formaldehyde gas takes quite a time for the fixation of the pulpal tissue. Due to larger molecular weight and the larger size of the glutaraldehyde molecules, they cannot diffuse out of the apical pulp or from the lateral canals of the radicular pulp. This prevents any toxicity to the systemic of the organism or system of the patient. Then the formicrosol, having a lesser molecular weight and the molecular site, it can diffuse easily through the apical pulp and can cause toxicity or even mutagenicity in the organism of the patient. Furthermore, the glutaraldehyde causes irreversible fixation of the tissues or the proteins. It causes both intramolecular as well as intermolecular binding of the bacteria as well as the pulpal proteins, whereas the formicrosol only causes reversible binding of the proteins and the bacteria. Formicrosol is also called toxigenic, mutagenic to the pulpal tissues as well as the system of the patient. Now, what is Swick's pulpotomy? It is also known as partial pulpotomy, which is performed in the young permanent tooth with open apices. It was first reported by Mijari and Swick in the year 1978. It is done by the medicament calcium hydroxide. Here, if suppose there is a trauma to the tooth or there is exposure of the pulp iatrogenically by the dentist or by the bacterial or mechanical means, or if there is a clinical and the radiographic criteria in which the root closure is not complete. In such cases, we do Swick's pulpotomy. The rationale for doing such type of pulpotomy is to preserve the vitality of the radicular pulp and allow the normal closure of the root apices. Now, coming over to the step-by-step procedure of the same. First of all, the first and the foremost procedure in everything is to anesthetize the tooth, then isolate the tooth by the means of a rubber dam or other isolation procedures also. And the coronal portion of the pulp is removed to perform a pulpotomy. The hemorrhage is controlled from the pulpal chamber by the means of a cotton pellet, and after completion or after control or cessation of the hemorrhage, we place a solution or we place a paste of calcium hydroxide, maybe either dical or other forms of calcium hydroxide, which is applied to the exposed pulp. But before that, we should ensure that the entire clot is cleared from the site. That is, calcium hydroxide should be in contact with the vital pulp. Later, the cavity is sealed with a temporary filling material or the intermediate filling material. The tooth should remain symptom-free. And after the formation of dental V, the dental bridge, that is after 5 to 8 weeks, permanent restoration by amalgam or the stainless steel crown or other restorative procedures is done. Now coming over to mortal pulpotomy. Mortal pulpotomy is generally called non-vital pulpotomy. It is done in those teeth which are non-restorable to the normal pulpal state, or in which the pulpal radicular portion of the pulp is having non-negotiable canals, or in the cases where the patient cooperation is very limited in the case of uncooperative patients. It is also done in handicapped children who are either mentally or physically handicapped or are unable to cooperate. Now, what happens in mortal pulpotomy is that all the necrotic pulp is removed, the pulp chamber is irrigated with a saline or other irrigating solutions, and the cotton pellet is placed. After cessation of any hemorrhage, the infected radicular pulp is treated by the means of a strong antiseptic solution like bleach with cresol, which will cause an antiseptic environment and prevent further growth of any organism in the pulpal tissue. In the second visit, if the tooth is asymptomatic, antiseptic paste is filled in the tooth after removing of the cotton pellet, and finally the tooth is restored by a stainless steel crown. But if the tooth is symptomatic, again the cotton pellet with bleachwood cresol is placed and the procedure is repeated. Now, before progressing to the current modalities of pulpotomy, The remaining procedures of pulpotomy are the other two types of pulpotomy according to the mechanism of action or the procedure are preservation type of pulpotomy and regeneration type of pulpotomy. In preservation type, as I have already told, we preserve a part of the dental pulp with minimum devitalization of the pulp. Herein, such chemicals are included which induce minimum devitalization or insult to the dental pulp tissue and further causing reservation or preservation of the part of the pulp that is vital. But no induction of the dentinal barrier takes place in this type of pulpotomy. The various medicaments used in such pulpotomy are glutaraldehyde, the ferric sulfate, and other medicaments like calcium hydroxide also can be used in such type of pulpotomy. Glutaraldehyde has reported further superior properties to formylcrysol or formaldehyde, as I have already told, because of its higher fixing capability, larger molecular weight, low diffusing capability to the apices, and further low systemic distribution, low toxigenicity, low mutagenicity, and even periapical leakage from glutaraldehyde is not there. It is one of the most potent germicide and tissue fixation properties are present in glutaraldehyde. The tissue fixation in glutaraldehyde is irreversible. It binds the intramolecular as well as the intermolecular proteins. The pulpal necrosis is minimum in glutaraldehyde and it fixes the pulpal tissue immediately rather than that of formylcrysol, which takes certain amount of time. Now, what is regeneration type of pulpotomy? Here, we induce a dentinal barrier to be formed by the means of certain inductive medicaments like bone morphogenic protein, can be either of bone morphogenic protein type 1, type 2, type 4 and type 6. The bone morphogenic protein induces osteogenesis, cementogenesis and dentinogenesis by the means of odontoblasts and the dentinoblast cells. So, other medicaments which are used in this are the freeze-dried bone, then mineral trioxide aggregate is also used. All these procedures of pulpotomy by the use of medicaments or pharmacological agents are having good results. But in an effort to make it more biologically acceptable to the patient system, non-pharmacological means are indicated. These are hemostatic techniques which incorporate lasers, then electrocautery, electrosurgery and other medicaments. These are the correct modalities in pulpotomy. They can be either by the means of electrosurgery, laser therapy and using mineral trioxide aggregate. Now, what is electrosurgery? What happens in this is the electric current or the electrodes are used to cessate any bleeding from the pulpal chamber. The electrode points are directly applied to the pulpal chamber or they are directly applied to the canals and the bleeding is stopped. This is a more biologically acceptable procedure. It was first reported by Mack in the year 1967. He was the first dentist to perform electrosurgical type of pulpotomy. It is a non-chemical devitalization process which is involved. It is more effective pulpotomy than the formylcrysol pulpotomy and the rates of success are higher. Many studies have been conducted on this type of pulpotomy. Further, Non-pharmacological hemostatic technique of lasers has also been suggested. MTA or mineral trioxide aggregate. It was first introduced by Trioxide in 1993 of Loma Linda University. It can also be used as a material for the induction of root end closure and preparation or the bridging of any furcation and the perforation repair. It provides an enhanced hermetic seal to prevent any further reinfection from the apical end of the tooth. MTA pulpotomy has been found to have successful results. Then other materials which are used in pulpotomy are bone morphogenic protein, as I have already told, type 1, type 2, type 4 and type 6 are the most prevalent one used, which induce dentinogenesis, osteogenesis and cementogenesis. The biodentine or the dentinal shavings are used to produce the dentinal matrix on which further calcification can take place. Hydroxyapatite, it again binds to the tooth structure for laying out the matrix and calcification of the tooth and forming of the dentinal barrier. Then freeze-dried platelet and calcium hydroxide has also been reported successful in the process of pulpotomy. Enamel matrix derivatives like albumin have been reported to form matrix formation in the pulp, further leading to the dentinal bridge formation and the repair of the irreversibly damaged pulp. Lasers have been indicated in pulpotomy. By the process, they have the ability to cessate any bleeding from the pulp chamber. Generally, NDE and argon lasers are used following 100% success in pulpotomy. So pulpotomy is a very good procedure and it's a reliable one too to save a badly decayed tooth. But due to the non-negotiability and unpredictability of the deciduous root canals, generally present cases, single visit pulpectomy is indicated. Thank you.